All right, everybody, on we go. Question 121. So, for this question, we have a 39-year-old woman with a history of prophylactic colectomy at age 22 due to numerous colonic adenomatous polyps, presents with progressive epigastric pain, weight loss, and jaundice. Her father died of colon cancer in his 40s. Exam shows scleral icterus and a palpable right upper quadrant mass. MRI shows a mass in the periampullary region obstructing the common bile duct. Biopsy of the duodenal polyp shows high-grade dysplasia. Molecular testing reveals what? Some things to look out for in this question, Sam, are you have a lot of polyps after puberty, and that's often due to a germline APC mutation. It's autosomal dominant, and it has 100% penetrance if it's untreated. Prophylactic colectomy. That's required to prevent colorectal cancer. And a duodenal adenoma is the most common extracolonic malignancy risk. And the mechanism here for FAP is you have an APC mutation, and APC normally regulates beta-catenin. And without APC, the beta-catenin accumulates, and it increases the transcription of growth-promoting genes, and that is how you get an adenoma formation. And this has a couple of associations, like Gardner syndrome. That's where you have FAP plus osteomas, and also an epidermoid cyst, which is like a benign, slow-growing cyst that appears on the skin, but also can appear in the brain and the spinal cord. Oftentimes, you see a little bitty cyst right there, right below the ear. But also with Gardner's, you can see dental abnormalities, also desmoid tumors. So that's Gardner's. You can also look out for Turcotte syndrome. That's FAP with a CNS tumor, like a medulloblastoma, and that's also driven by your APC mutation. It just affects the neuronal proliferation. And hepatoblastoma is seen in children. And for that one, you definitely need surveillance. But also your straight up duodenal and pancreatic cancer. These guys can cause problems because your APC will be lost, and that allows your GI tract polyp growth to extend beyond the colon. So the pathophysiology is that you have a first hit that's inherited on the chromosome 5q21. That's typically where it's found. It's autosomal dominant. And then you have and that second hit would fulfill that Knudsen's two-hit hypothesis, and you start to have the polyp formation. So adenocarcinoma sequence will happen due to that chromosomal instability, and then it progresses to a carcinoma through additional mutations. For instance, you have your CRAS mutation. This is all after that second hit, by the way, and P53 mutation, and then the cancer's off to the races. But APC is a tumor suppressant gene on 5q, and you have to do a prophylactic colectomy. That means a surgical removal of part or all of the colon, and screening starts at 10 years with a yearly sigmoidoscopy. That's just basically an examination of the sigmoid colon. They put in a flexible tube through the anus. So the CNS tumors, think Turcotte syndrome. And a good thing to know too is that without colectomy, if you don't take it out, then you're going to get cancer. It's 100% by age 40. And so our answer is the biallelic loss of the tumor suppressor on chromosome 5. That's classic for your duodenal adenocarcinoma. Here's some other answers and why they're wrong. CRAS is later. It's 1 is seen in sporadic microsatellite instability of colorectal cancers, not FAP. Microsatellite instability would be Lynch syndrome. That's due to defective DNA mismatch repair. BRAF common in melanoma and some sporadic cancers, but definitely not your FAP. All right, there's 121. On to 122. PSA, don't smoke. In this practice question, we're evaluating the impact of industrial air pollutants. Mice are exposed to sulfur dioxide for 7 days. An analysis of their pulmonary epithelium shows increased numbers of goblet cells, numerous carbon-containing alveolar macrophages, and reduced motility. Which of the following is most consistent with this exposure? You're going to have increased mucus production, decreased alveolar function, and decreased ciliary activity. Basically, things just ain't working anymore. And the reason you have increased mucus production is due to those goblet cells. They undergo hyperplasia, that's submucosal gland hypertrophy. You would also see decreased ciliary activity because the toxins in the smoke are going to paralyze and destroy the respiratory cilia. And you'd have inhibited macrophage function because there's impaired phagocytosis and antigen clearance. Now, the associations you should know about on test day are first chronic bronchitis. Ain't nobody got time for that. Defined clinically by productive cough of greater than 3 months for greater than 2 years, and is directly tied to the increased mucus and impaired clearance problems that you have with smoking. Centroacinar emphysema is also another one. So emphysema is a condition where the air sacs in the lungs are damaged or enlarged, and that causes breathlessness. You have alveolar wall destruction that's due to increased protease activity, so it's via the neutrophils and the dysfunctional macrophages. You can also see respiratory infections, that's impaired mucociliary and macrophage defenses that allow the bacterial and viral colonization. And worst of all, arguably, you can have squamous metaplasia. That's the loss of the ciliated pseudostratified epithelium. It gets replaced by non-squamous epithelium in smokers. So tobacco toxins damage the airway epithelium. They paralyze and destroy the cilia. Goblet cell hyperplasia and gland hypertrophy can happen, and you have increased mucus production. It gets sticky and poorly cleared. Secretions are everywhere. Macrophage dysfunction occurs, and you have decreased microbial clearance. So you can also have increased pro-inflammatory signaling. And with chronic exposure, you can have inflammation, obstruction, and infection. So you have COPD and cancer risk as well. So you're going to see more mucus production, Think of like the thick, viscous stuff. Ciliary function goes down, so you have the slowed clearance of particles. Alveolar macrophage function goes down. There's reduced phagocytosis and antigen handling. So you get goblet cell metaplasia, squamous transformations, chronic inflammation, risk of bronchitis, pneumonia, and COPD. So it's a bad deal. Don't smoke. You have increased production of the mucus and thicker, harder to clear, problematic airway cilia damaging, decreased clearance ability. It's just a really sad deal. So I bet you didn't know that the smoking actually paralyzes. Your airway cilia will be paralyzed. Next question, kind of easy. 68-year-old man, low mood, some disturbances after his adult son was in a car accident. Sometimes he dreams about his son, and he cries when passing his son's favorite restaurant. He still attends church, participates in book club, and enjoys walking his dog. What's the most appropriate next step? It's just regular follow-ups. We have uncomplicated grief, and that's important to distinguish on test day. More than half of grieving adults over the age 65 experience sleep changing and early morning awakening, so that's not actually a symptom here. I mean, it is one that's worth, but you need 5 for SIGI-CAPs before you start prescribing antidepressants. It's not first line. You can also begin cognitive behavioral therapy. That can be helpful, and I would recommend it actually, but on test day, this is uncomplicated grief, and so it's not going to be the right answer. D, neuropsych testing, you're fine. He doesn't have dementia or complex grief, and you don't prescribe medication or sleep aids unless it's absolutely necessary. All right, 124. Here we got a 45-year-old man, history of adult onset asthma, presents with fatigue, weight loss, and tingling in the feet. There's also worsening shortness of breath, occasional hemoptysis. There's bilateral wheezing and decreased sensation and stocking glove distribution. Important labs show eosinophilia and elevated creatinine. T shows patchy peripheral infiltrates. Kidney biopsy shows necrotizing vasculitis with eosinophilic infiltrates. That's a super dead giveaway. What's the diagnosis? It's going to be eosinophilic granulitis with polyangiitis. EGPA, this is a triad to know about, is the asthma, eosinophilia, and small vessel vasculitis. You see neuropathy, pulmonary infiltrates, and biopsy findings for EGPA. It's also known as Churg-Strauss syndrome. Again, just know these 3: asthma, eosinophilia, small subvasculitides. That's when you have inflammation of the blood vessels. You could also have pleural effusion, peripheral infiltrates. That's pulmonary involvement, and eosinophilic necrosis. So what happens here is there's an allergic inflammation. You get eosinophils, and then it causes vascular injury. And so it's necrotizing granulomatous vasculitis. There are some associations to be aware of. Pianka is one of them. It's found in 40 to 60% of your EGPA patients, and it helps differentiate between GPA, because GPA is Cianca. Pianka goes with the P here. There's also mononeuritis multiplex. It's caused by damage to separate peripheral nerves in a non-symmetric pattern. It's just a pattern of nerve damage to be aware of. You'll see it on your wrist, also like some foot drop. You might see peripheral nerve ischemia from small vessel vasculitides, and then cardiac involvement as well, eosinophilic myocarditis. That's the major cause of death in EGPA. It can affect the heart. You'll have skin nodules, palpable purpura, and glomerulonephritis. It's less common, but it's possible. It presents with nephritic syndrome. So the pathophysiology is that you have the early phase where you have allergic symptoms, asthma, rhinitis, and then you have the vasculitic phase. That's the necrotizing granulomatous inflammation phase. You get the MPO, the Pianka involved, and those antibodies promote neutrophil activation. That causes vascular damage. Key features are asthma, allergic rhinitis. It's always going to be present every single time. Lung findings as well. So pleural effusion, peripheral infiltrates. Pianka will be seen in 50% of the cases, and also the treatment is high-dose steroids. And you can use cyclophosphamide for some severe cases. So our answer is B. It's not microscopic polyangiitis. That would be the post-immune glomerulonephritis and alveolar damage, but you would not see the allergic features with this one. Granulomatous with polyangiitis, that's classic for nasal ulcers, hemoptysis, and hematuria, but there's no eosinophilia and asthma. And this guy is granulomatous is associated with C. Onca, and necrotizing granulomas, but not allergic stuff. And then sarcoid has non-caseating granulomas. And this will be like black females with hilar lymphadenopathy and accelerated ACE. Hypersensitive, that's caused by organic dust inhalation, not vasculitis. Presents with diffuse interstitial lung disease, non-neuropathy, and multisystem eosinophilic inflammation. So that one's going to be like farmer's lung or bird fancier's disease. All right, moving on to the next one, 125. We have a 64-year-old man who's found to have left-sided hydronephrosis and abdominal ultrasound during evaluation for flank pain. 40-year smoking history, reports intermittent painless hematuria. Cytoscopy is unremarkable. CT shows mass on the distal left ureter. Biopsy shows papillary lesion composed of atypical urothelial cells. What's the most predisposing factor? So let's do some risk factors, shall we? This is super high yield for schistosomiasis. That causes squamous cell carcinoma. It's found in endemic to areas like Egypt. Radiation therapy, that can cause secondary malignancies like thyroid or leukemia, but definitely not the urothelial cancers. Chloride is linked to hepatic angiosarcoma. Cyclophosphamide is strongly linked to bladder cancer, but it's not typically urothelial lesions unless it's a long-term exposure. So good guess, but not quite. So yeah, it's cigarette smoking again. And this doesn't just wreck your lungs, it also poisons your urinary tract. The entire urothelial lining from your kidneys to your urethra is exposed to carcinogen in cigarette smoke every single time that you pee. That's why urothelial carcinoma, also known as transitional cell carcinoma, is most commonly linked to smoking. So if you have unilateral hydronephrosis and a mass in the ureter causing blockage, it's urothelial cancer. So cigarette smoking is the #1 cause. Benzenes, that's linked to leukemia, Epstein-Barr, nasopharyngeal carcinoma, UV radiation, skin cancers, melanomas, soma infections of squamous of the bladder, not transitional cell. So I think the hardest one here is the schistosomiasis. It's important to know this is not squamous cell. And the difference histologically is like squamous cell, you have keratin pearls, but for the basic urothelial carcinomas, you get transitional epithelium. So if the histology were to show keratinization in squamous cell, or they're from Egypt or Sudan, then sure, schistosomiasis. But if it's urothelial histology and then a smoking history, then probably transitional cell. So the bottom line is schistosoma would cause squamous cell. Schistosomiasis, squamous cell, they even seem like each other. Look at all those S's. But this is urothelial cancer of the ureter. And so that's cigarette smoke. All right, on to 126. 30-year-old woman, 22 weeks gestation, presents with a routine prenatal care. She's feeling well, but sometimes she feels more out of breath when walking upstairs. What's the explanation? Could it be that she's pregnant? Well, yes, there are a lot of pregnancy-induced changes. So some of them are in respiration, like you have respiratory alkalosis, and that's due to the fetal CO2 load. So you'll hear from these pregnant women that they feel fine, but they're breathing faster. They have no fever, no cough, no embolism. The fetal metabolic CO2 causes maternal exhalation. And the mechanism at play here is there's fetal CO2. So here's your little baby. It's got the CO2 and it crosses the placenta and it increases the maternal CO2. So now mom's CO2 goes up and progesterone increases the respiratory sensor. So that's the placental gas exchange where you have passive diffusion and it favors maternal excretion of fetal waste. The bottom line of the pathophys is that the fetal metabolism produces CO2 and CO2 diffuses into maternal blood through the placenta. And then the maternal chemoreceptors detect the increased CO2. They're like, oh my gosh, progesterone then sensitizes the respiratory sensor, it causes increased minute ventilation, and you get mild respiratory alkalosis. That's expected and it's totally normal. So this is normal in pregnancy. No signs of infection is what you should look for in the question stem. There's no pulmonary embolism. And also the uterus is at the umbilicus like 20 weeks in. It's just too early for a diaphragm pressure. And that's what you should be looking for in question stems like this, so that you can say, okay, there's some alkalosis that's due to the respiratory compensation because of all of that CO2 that the baby is given to mama, right? That CO2 makes you want to breathe because of progesterone's impact on the ventilation center, the central ventilation center in your brain, and they're going to be breathing really quickly and compensating for that ventilation to eliminate the CO2. So that's what's going on here. And some things to look out for is like pulmonary embolism that would cause dyspnea, chest pain, and hypoxia. There's no chest pain here, so it's not that as an answer. And then uterine pressure, that happens a lot later on, like 28 weeks or so, or even more than that. And that's when the uterus, it'll compress the diaphragm significantly. Not pneumonia, because there you'd see cough, fever, crackles, and there's no evidence of infection in this woman. And the fetal lung maturity or immaturity is totally irrelevant to the maternal respiratory physiology. The fetal lung maturity does not trigger maternal breathing changes. So there's a reason why pregnant women breathe faster. It's because they're breathing for 2. Even when they're feeling totally fine, it's not like anxiety or infection related. It's literally because the fetus is offloading its CO2 into the mom's blood. And guess who clears that CO2? Mom's lungs. And so it's thanks to the progesterone that her brain is more sensitive to the rising CO2 levels, and so she breathes much faster. It's a natural compensation for maintaining gas exchange. And so 20 weeks pregnant, it's too early for a lot of the other signs and symptoms we'd look out for in the question stem. It's not an embolism because there's no chest pain, not infection, there's no crackles and difficulty breathing. It's just respiratory compensation. That's all that's going on here. All right, next question. There's a rule about half-lives, and that is for 127. It takes 5 rounds. There's just like this rule we have to know. 5 half-lives, doesn't matter what the frequency is. Half-life, it depends on the clearance and the volume of the distribution. So there's this formula that we have to know here. So all we want is just 5 half-lives. So new antibiotic has 40 and 5. What's the half-life of the drug? We use this formula and we find that it's C. So drugs with a high volume of distribution have a longer impaired clearance, would increase the half-life. And zero order is the constant amount eliminated stuff. Phenytoin, ethanol, aspirin. So it reaches 97% cleared after 5 rounds. And here's our formula. Volume of distribution divided by the clearance times 0.693. Moving on to 128. For this question, a 31-year-old woman is enrolled in a study on tumor immunology. Which tumor type and associated antigens generates the highest antibody titers? Is it non-Hodgkin's and CD20? Well, those are self-proteins. And pretty much all this question's getting at is the more foreign it is, the more response you get. So E6 protein from HPV is viral. It's non-human, that is to say. And so the immune system sees it as a complete outsider. It sees this E6 and it's like, OMG, we got to attack it. That's so weird. So there's tons of antibodies that are produced that has the highest titer. The other ones, the other answer choices, they all have some like kind of endogenous actions. They're all like, better said, they're all normal human proteins. They're just overexpressed. And so you wouldn't have an immune system reaction. In fact, your immune system just kind of ignores those guys unless it's tricked or modulated by therapy. So self-antigens have a weak response and viral antigens have a super strong one. And that's why HPV-6 protein in cervical cancer is definitely not you. It's like not you at all. So the body freaks out, but in a good way. Whereas CD20 is found on B cells. CEA, that's an oncofetal antigen re-expressed in malignancy. MART would be melanomas. So again, it's endogenous, weakly immunogenic. And PSA is normal prostate enzyme increased in malignancies. So basically, what's most foreign? Whatever's most foreign is going to be a virus. And so the answer to what causes the most titers is always some sort of a virus. Now, they could have given other ones like HER2, that's human protein, it's just overexpressed. CD19 is also B marker. Tyrosinase, that's an enzyme in the melanin synthesis. So it's, again, anything that's like self is not going to cause a huge eruption. All right, so moving on to 129. All right, here's our question for 129. A neuroscience researcher is studying energy-dependent neurotransmitter clearance in rodents. Brain tissue shows extracellular glutamate and downregulation of EAAT transporters. Which type is most likely dysfunctional first? Okay, let's break down some concepts here. The astrocyte, what is it? As you can read here, it says they're central players in clearing glutamate. What they do is essentially they're CNS glial cells that maintain neurotransmitter balance, especially glutamate. They use high-affinity glutamate transports to clear excess glutamate from the synapses. So they get all that glutamate and they send it to the astrosphere. Whoosh, bye glutamate. This prevents excitotoxicity and neuron death due to too much glutamate. Again, it launches the glutamate into space. So in Wernicke encephalopathy, you have thiamine deficiency. And thiamine deficiency causes astrocyte dysfunction. You need thiamine for the astrocytes to be able to work properly. So they're not going to be able to clear enough glutamate if you have encephalopathy. And a bunch of glutamate buildup is a classic brain atrophy problem in the mammillary bodies. And that's the reason why we have problems with Wernicke's encephalopathy. Microglia, these are the scavengers. They activate after injury, not before. Oligodendrocytes, these myelinate the CNS axons. Neurons suffer secondarily from glutamate, but it's not the first cell impaired. And endothelial maintains the BBB. Now, what about ependymal cells? Now, these guys line the ventricles of the brain and the central canal of the spinal cord. They help circulate cerebrospinal fluid using the cilia, and they form the barrier between CSF and the brain tissue. So ependymal cells are actually not involved in glutamate reuptake and you have minimal glutamate regulation compared to astrocytes. However, if they were asking about, hey, what helps circulate the CSF in the brain, then yes, I would pick ependymal cells as the answer. Microglial cells, these guys are the immune system cells of the CNS. It's kind of like the macrophages. They clean things up. And I don't know why, but glial reminds me of like gathering up things in the CNS. They glial, gather all the stuff. It's like a macrophage. They clean up the dead cells, the pathogens, the debris. And they release the cytokines and they mediate the inflammation. They're not involved in neurotransmitter transport and synaptic regulation. Their job is just the damage control. It's after the damage, it's not before. And oligodendrocytes, they make the myelin. They're the myelin makers. And they speed up the action potentials via saltatory conductions. And the Schwann cells, they myelinate the PNS. And that's helping with regeneration stuff. So oligodendrocytes are going to speed things up and Schwann cells are going to regenerate things. And it's not involved in glutamate metabolism at all. So astrocytes are the high affinity glutamate transporters, and they remove glutamate from the synaptic cleft, and it prevents cytotoxicity. And in thiamine deficiency, Wernicke encephalopathy, astrocyte dysfunction, so they can't work properly, so the glutamate sticks around and it causes selective neuronal death. That's how it all works, folks. In this one, we have a 29-year-old woman. We'll zoom out here because we're on 130. Wow. Work, folks. 29-year-old woman, she has schizophrenia, and she has switched from risperidone to a new medication after developing hand tremors and muscle stiffness. Her new medication acts by partially stimulating dopamine receptors, providing enough activity to preserve basal ganglia function while still reducing psychotic symptoms. What's the mechanism of action? It's a dopamine receptor partial agonist. Now, unlike full antagonists like haloperidol, these guys will fully shut off dopamine activity. The partial agonists like aripiprazole preserve basal signaling, so that reduces the extrapyramidal symptoms and controls psychosis. So aripiprazole is a partial D2 agonist, and that one's a tricky one because it sounds like it's just going to be one of your proton pump inhibitors, like omeprazole, pantoprazole. And those guys do inhibit, like all of your PPIs, the proton pump inhibitors, they inhibit the hydrogen-potassium ATPase pumps in the stomach, and they reduce acid that way. But aripiprazole is an atypical antipsychotic, and it has partial D2 agonism. So if you want to know, it is not a benzydimal PPI like omeprazole. It's not that at all. It just shares the suffix with it. All right, we're going to go a little bit quicker here. 15-year-old boy has comedonal acne on the forehead and the chin. Physician prescribes topical medication that binds to a nuclear receptor and modifies gene transcription, leading to decreased keratinocyte cohesion and increased epidermal turnover. Which agent is most likely prescribed? Adapalene. Tretinoin. is probably the answer that you'll see on test day. But basically, acne vulgaris is what we're dealing with here. And you're going to see that fancy word comedone, which is the technical term for just blackhead. So blackheads and pimples, just classic acne, right? You have decreased cohesion between the epidermal cysts, and so retinoid is what you should be thinking of there. So tretinoin is a vitamin A derivative, and it binds the retinoic acid receptors, and it normalizes keratinization, unclogs the follicles, and prevents new acne lesions by increasing transcriptions of genes that regulate the epidermal cell turnover and reduce keratinocyte stickiness. So topical tretinoin is the first line for mild to moderate acne. And you can also take it orally, and that's used for severe nodular cystic acne. And the side effects are photosensitivity, dryness, and teratogenic if it's oral. And it works pretty slowly. It takes about 8 to 12 weeks before you start to see improvement. But what happens there is that it increases androgens during puberty, like the pathophysiology of the acne here. Is during puberty, you have increased androgen, and that stimulates your sebaceous glands, and then you have sebum and abnormal keratinization, so the follicles get blocked, and you have comedones. And then you have bacteria, Cutibacterium acnes, to be precise, and that causes inflammation. The retinoids reduce follicular plugging, and it prevents the comedone formation. And retinoids don't treat the inflammation directly. They do, however, prevent the lesion formation. And so the target here is the keratinocyte adhesion turnover, and it doesn't directly kill the bacteria. That's benzoyl peroxide's job, or other antibiotics they might take, like doxycycline can be given, I think. It's used for prevention, not spot treatment. And there's a photosensitivity warning, right? You got to wear it with sunscreen. There's an oral antibiotic that's used for inflammation. Clindamycin, often combined with retinoids, but no effect on keratinization. Salicylic acid works non-transcriptionally, unlike your retinoids. All right, for this next one, 132, I just wanted to explain a small thing. If I were to say odds ratio, which study would you think of? You should be thinking of the case control, because that's the people with and without disease, and you look backward. You start with who's odd. You do case control on them. Cohort, without exposure, follow forward, relative risk. Cross-sections, disease at the same time, prevalence. Case series, just description of cases. Ecologic population level, RCT, gold standard. All right, that's all you need to know. So outcome first, exposure second. Odds ratio is going to be used here. So if we're looking, for instance, if this question were to be about artificial sweeteners, and if it's linked to multiple sclerosis, you get 200 people with multiple sclerosis and 200 matched individuals who are healthy. And then you survey their past consumption. What type is that? Case control. Why? Because you start with the disease. You look at the odd people, and then you look back. Odds ratio. All right, now this is a fun question. I like this one. 27-year-old woman with chronic heartburn enrolls in physiology research study on gastric acid secretion. Her parietal cells are observed to secrete 500 nanomoles of hydrogen ions. Assuming normal function of these hydronium potassium ATPases, how many ATP molecules are consumed? It's going to be the exact same, because each proton requires 1 ATP. And so 500 secreted, well then 500 of ATP is consumed. It's a 1-to-1 stoichiometry. All right, for 134, let's say we got a dude who's got he's a 46-year-old warehouse worker, tingling in lateral forearm, reduced strength, raising his right arm above his shoulder level. This hurts. Neurologic exam shows sensation over the deltoid region, and you just have to know which spinal roots are there, and it's going to be C5, C6. So that's deltoid and supraspinatus innervation needed for abduction of the shoulder. So C5, C6, shoulder abduction. This could be because of like a neck stress, like disc bulge thing, compression of the neural foramen, impingement. You could also have some possible reflex loss, like the biceps or C5 and the radialis. The C5, C6 nerve roots supply the deltoid and the supraspinatus, and so that's shoulder abductors. There's also something to know about how high you can raise your arm in the upper limb movements. So the muscle, the supraspinatus, that does the first 15 abduction. So 0 to 15 is the supraspinatus, and then 15 to 90 degrees is the deltoid, and then above 90 or overhead, that's trapezius and the serratus anterior. So supraspinatus, deltoid, trapezius, serratus anterior. That overhead motion as the trapezius, and then up to 90 is the deltoid. And you can know this just by like feeling it. Just put your arm out on test day just to be double sure. But yeah, C5, C6 does a lot of that. I mean, C7 is when you start to get into the long thoracic stuff. But yeah, I mean, like lifting your shoulder to 90 degrees is C5, C6, and that's going to be our answer to this question. All right, moving on to 135. We have a 16-year-old boy, chronic diarrhea, failure to gain weight. Physical exam shows dry and diminished vibratory sense in his feet. Labs show decreased serum cholesterol, LDL, VLDL, and chylomicrons. So it's a defect in ApoB because he's having vitamin E deficiencies. So he's got familial hypo-beta-alipoproteinemia. And we know this because he's got steatorrhea since childhood. That's fat malabsorption. And this is going to have a family history that's autosomal dominant inheritance, and that's why it's seen across his family. So the ApoB gene mutation basically decreases a lot of things, but like ApoB48, Tai Ni Ma Ra, Ni Ma Ra La, Shu, Cow, Bus. And then I know that 8 is V, so it's rave. And I think of people on a chylomicron like raving. And that's how I know that it's ApoB48 chylomicron. That made no sense. Don't worry about it. Maybe just Google PEG system. It's super helpful for med school. But yeah, ApoB48, rave. they're raving on the kilomicrons. That tells me it's 48 kilomicrons, and this could cause that lower kilomicron. And then also you have your hundreds, so that's the tosses. I remember it's tosses because no. So this is 0 has the S sound, and then this has the T sound, which tells me tosses. So I imagine VLDL is like tossing something in the air. I'm just telling you right now how I use the PEG system to remember all the numbers of kilomicrons and VLDLs and all that stuff. So ApoB, it's being tossed in the air, and it's a very long toss. And that tells me that it's ApoB 100. I'll make another video on that at some point if you guys just like and subscribe or comment that you want to learn it. Super helpful way. And another thing that's like super key to this question is fat-soluble vitamins. They're all over this test. Guaranteed to see this. Basically, you have neurologic issues, rickets, coagulopathies for depending on which vitamin you're deficient in. Also hepatic steatosis, that's the impaired liver export, so you have fat buildup in the liver. And the treatment is just going to be high-dose vitamin E, right? You protect your neurons from oxidative damage. That's all you need to do here. And the problem is that we can't make VLDL in the liver because we have ApoB 100 deficiency. So we have low VLDL, low LDL, and low total cholesterol, and we have unabsorbed fat, so there's energy deficiencies and vitamin deficiencies, and that's causing his neurological problem. That's all there is to that one. Moving on to 136. A 22-year-old woman has dizziness and fatigue after a week of profuse watery diarrhea. What explains her acid-base stuff? Well, diarrhea, you'd have decreased pH and decreased PaCO2, be metabolic acidosis with respiratory compensation. So she's had a lot of that diarrhea, and that's probably what's causing her symptoms, but we have non-ANGAP metabolic acidosis. Anytime you have a pH less than 7.35, then it's acidemia, and that's when the respiratory system is compensating for the acidosis by increasing the minute ventilation. So basically, you're trying to get rid of CO2 because it's already too acidic. You'll see like very low PCO2 levels. And the buzzwords, the important things to think about for a question like this is anytime they have diarrhea, that's going to be non-anion gap metabolic acidosis. Hypotension will be seen, dry mucosa, and a high heart rate. And that's all because of volume depletion. You have low potassium, low bicarbonate. That's the GI loss and the renal compensation. And then low PCO2, and that's the compensation of respiratory alkalosis. So in diarrhea, you lose your bicarbonate. The colon fails to reabsorb it. And so that causes acidosis. Also, volume depletion occurs. And so increased aldosterone, and then that promotes the renal potassium wasting. So we lose potassium, both from the GI loss and also aldosterone-mediated renal loss. And then we have hyperchloremic acidosis because the chloride is going to rise to maintain the neutrality because our other negative theme has just been lost, i.e. bicarbonate. And so now we have to have more chloride. And so then we have watery diarrhea, loss of bicarbonate and potassium from the stool, decreased volume, activating the RAS system, which activates aldosterone, which then makes it even worse because we have more K potassium secretion. Next, we have a 33-year-old man with AIDS, new onset seizures. He has not been on antiviral therapy, and he has a CD4 count of 45. MRI reveals 3 enhancing lesions. Wow! He started on empiric therapy, pyrimethamine and sulfadiazine, and a stereostatic biopsy confirms tachyzoites. What's the route of transmission? It is fecal-oral, baby. This is Toxoplasma gondii. So this has a fecal-oral ingestion route, and you can read about it here in the brief explanation above my head. Check that out. And this green screen so cool. I mean, what green screen? I live here. I live in this screen. I'm just joking. Or am I? But yeah, the associations, what you should look out for on test A and in real life. Watch out for that undercooked meat, yo. I was in Guatemala and they're like, hey, this is chicken heart. Take it. And it was like cold. Ooh. Anyways, pork, lamb, anything that causes like those bradyzoite cysts. Also cat feces, they can have oocyte ingestion. That's why pregnant people should avoid litter boxes. It can also be reactivation in HIV and AIDS, particularly because the CD4 count is going to be like less than 100 here. Also, you'll have a positive IgG titer. That's poor exposure reactivation. It's non-new infection. So the pathophys is you have an initial exposure via ingestion of the oocytes. It's cat feces or tissue cysts through the meat. Then the parasite forms latent tissue cysts. And then competent patients are usually asymptomatic, but then you have immunosuppressed people, like you have AIDS and you get a reactivation of the latent infection. And the local tissue inflammation occurs and you have necrosis. So then you get those ring-enhancing lesions. The exposure is the undercooked meat or the cat feces. You'll see the crescent-shaped tachyzoite on the biopsy. By the way, the tachyzoite is just the rapidly dividing lunate-shaped parasites that are approximately, well, they're just like pretty tiny. And they have like a central nucleus and they can infect various types of cells, and that occurs when your CD4 is less than 100. And the treatment is sulfadiazine and pyrimethamine. You can also do prophylaxis whenever your CD4 count is below 100 of TMP, SMX. And what you really need to be able to single out here is why this is not HSV. Because in toxoplasma, we have your HIV positive seizure. The MRI shows a solitary enhancing lesion, and the biopsy can have lymphocytes, macrophages, and crescent-shaped organisms. It can be very similar to HSV, right? Because you can have multiple ring-enhancing lesions, is classic. But sometimes it can be solitary in toxo. And that's increasingly becoming the case because they're catching on. The students know that. And then HSV would be diffuse temporal lobe involvement. So it's often bilateral and it's not ring-shaped. All right, so HSV is diffuse, often bilateral, not ring-shaped. On biopsy for toxo, you see the crescent-shaped stuff, but for HSV, you would see these Cowdrey bodies, the Cowdrey type A inclusions, and also you'd see some neuronal necrosis. So necrosis, hemorrhage, inclusion bodies. And the treatment for HSV is acyclovir. But a big difference too is the symptoms. You have an HSV rapid onset encephalitis, confusion, severe headache. Also note that they'll mention the temporal lobes for HSV. I do think it's also important to know some modes of transmission. So ingestion is fecal oral. So think toxo, giardia, EHEC, ETEC, hepatitis A, E, all that stuff is chomp chomp, eat it up, fecal oral. But also you can have bloodborne stuff. That's when the pathogens bypass the barriers via transfusion or needle stick. So that's like HIV, HBV, HCV, also Babesia, CMV. And then there's sexual transmission, and that's like Treponema pallidum, that's syphilis, gonorrhea, chlamydia, HPV, HSV2. And then inhalation and droplets like airborne stuff. That's Mycobacterium tuberculosis, influenza, COVID-19, Neisseria meningitis, histoplasma, coccoides, and the cribriform plate. That's organisms that go directly through the olfactory nerve. That's the Fowleri, the freshwater disease up the nose. Also, mucormycosis is a sinus invasion. The cavernous sinus thrombosis would be an example of that. So just keep those in mind as you're thinking about answer choices of transmission, because sometimes they don't even tell you what the organism is. They just tell you how it's transmitted, and they expect you to know, based on the modes of transmission, what it is. All right, for this one, we got researchers developing a malaria vaccine that targets the liver stage of the parasite's life cycle. Immunization sees the expansion of CD8. Which process enables this T cell activation? The answer is the processing of cytoplasmic malaria proteins for class 1 MHCs. So let's talk about how malaria activates the CD8 positive T cells. So malaria, Plasmodium, gets inside of the liver cells, hepatocytes, and once it's inside of the cell's cytoplasm, the parasite proteins are broken down and shown on the cell surface using MHC class 1. We'll zoom into 138 here. And CD8 positive T cells recognize this, and then they attack that infected cells. Now, it's not endocytosis. That would be MHC class 2, not 1. And malaria does not make fake MHC molecules. Also, malaria does not steal MHC from humans, and there's no superantigen in malaria. That's more like staph infection stuff. And so only things inside of the cell cytoplasm go to MHC class 1, and that will trigger the CD8 positive T cell response. And malaria invades the liver cells, and so that's how the immune system knows to send the killer T cells. So here's an explanation. They infect hepatocytes when they replicate in the cytoplasm. And that lets these guys, because it sees this in the cytoplasm, and the CD8 positive T cells to activate and kill the infected cells. Red blood cells, though, lack nuclei, and so their response is going to be in a different stage, not the livers. So broad strokes here, the mosquito bites you and injects malaria. Malaria goes inside your liver cells. It does not stay on the outside. And inside the liver cell, malaria makes proteins, and your liver shows those proteins on its surface using something called an MHC class 1. And then your CD8 positive T cells see that little red flag that these guys put up. They're like, ooh, that's a red flag. That is why processing of cytoplasmic malaria proteins for class 1 is the correct answer in that liver stage. It's not going to be like endocytosis, because that would lead to CD4 positive activation. Same with the endosome, lysosome fusion stuff. They're just presenting them. That's how malaria gets caught and destroyed. All right, here's our next practice question. For 139, we have a 19-year-old college student, has worsening facial hair and irregular periods since age 14. She has no history of early puberty and electrolyte abnormalities. Physical exam shows hirsutism, acne, and mild clitoromegaly. So what's happening here is there is a 21 hydroxylase, late onset CAH. She has androgen excess. That's because of elevated 17 hydroxyprogesterone and no salt wasting. Here are the trap answers that you can see. So starting with this top one, 11 beta hydroxylase deficiency causes estrogen excess but includes hypertension due to the 11 deoxycorticosteroid buildup. And aromatase deficiency would lead to excess testosterone, lack of estrogen, and tall stature with delayed epiphyseal closure. So late onset 21 hydroxylase deficiency. This is neoclassic congenital adrenal hypoplasia, CAH. It's late onset here. So you have hirsutism, that's the excess facial body hair, and that's because of the androgen excess. And clitoromegaly is the virilization, so that's the external genitalia changes in the genetic female. You'll have increased the 17 hydroxyprogesterone, that's the shunting of the precursors. And you have normal blood pressure and electrolytes. That's how you know it's not an 11 deficiency, because that also causes androgen excess, but then you have hypertension there. And this is autosomal recessive. Also, it's seen with CYP21A2 mutations in the family history of ambiguous genitalia, infertility and virilization, and increased ACTH due to cortisol deficiency. It's adrenal hyperplasia. And so you can't make cortisol or aldosterone if you have decreased 21 hydroxylase. And so precursors like 17 get built up, and those excess precursors turn into androgen synthesis. And in females, this causes virilization, hirsutism, and menstrual issues. All right, moving on to 140. Now we have a 28-year-old man who is found unresponsive. His roommate says he has a history of IV drug use. On exam, he's somnolent and respiratory rate of 6. Wow. Okay, so it's heroin overdose. So he's got CNS depression, meiosis, and respiratory depression. That just tells you it's an opioid. And heroin is an opioid, and that's all you need to know. Just for the funsies of it, let's look at the trap answers. Benzos causes sedation, but no meiosis. The pupils are fine there. Cocaine dilates the pupils. PCP causes violent behavior, LSD, hallucinations, and mydriasis. So the pupil is going to be big there, big here, and also altered perception would be seen. So morphine, fentanyl, codeine, all these opioids like heroin, that's what we're talking about here. It's IV drug use, and there's a risk of HIV, hepatitis, and skin abscesses, and naloxone is the antidote. It's rapid reversal of the CNS and respiratory stuff. And the pathophys here is important. So the pathophys is that the opioids bind to the mu receptors in the CNS, and that's the brainstem and the spinal cord. That decreases the neuronal excitability, and so you get CNS depression and also sedation. And in 3, we inhibit the medullary respiratory centers, and that decreases our respiratory drive. And then in 4, we activate these parasympathetics, and you have pupil constriction, because that's what happens with the parasympathetics, you get the pupil constriction. And then GI motility is also decreased, which causes constipation. So like the reason why there's decreased neuronal excitability and CNS depression is because opioids like heroin bind to the mu receptors, which are GI, they're inhibitory proteins that are coupled receptors, so GPCRs. This activates the potassium efflux, so you're getting rid of that positive and it's hyperpolarizing them, so it's harder to fire the action potentials, and also a decreased calcium influx of the nerve terminals, and that's decreased neurotransmitter release like glutamate, and that's sedation, stupor, and coma. But there's also the mu receptors, and those are densely located at the medulla, and those are specifically the pre-Boltzinger complex of the nucleus, and those are areas that generate the breathing rhythm, and when opioids suppress the activity there, you have decreased response to carbon dioxide buildup and the brain signaling to respiratory muscles. And so you have slowed, shallow breathing, the respiratory depression, which is the big cause of death. And also the activation of the parasympathetics occurs because opioids activate the Edinger-Westphal nucleus in the midbrain. And that's the parasympathetic, right? So that's leading to activation of cranial nerve 3, ocular motor, and that's the pupil constrictor muscle, the sphincter pillae, and it contracts, right? So you have pinpoint pupils because of that. And also GI motility is decreased because the mu receptors are also enteric nervous system. They're found there. And so you have decreased acetylcholine release from the enteric neurons and decreased peristalsis. And you might be thinking, okay, well, I thought the parasympathetic would boost the gastric stuff. So normal parasympathetics, rest and digest, does increase gastric motility. Under normal circumstances, parasympathetic via the vagus nerve stimulates acetylcholine release through the enteric nervous system, and that causes the increase of smooth muscle contraction and peristalsis and all that good stuff. So yes, parasympathetic activation does cause the more pooping and more movement. But opioids, they inhibit the pathway despite parasympathetic tone. And so the twist with opioids is that they bind to these mu receptors that we mentioned in the gut wall, especially the myenteric plexus for motility and the subplexus for secretion. And these mu receptors are GI coupled, and so they actually decrease acetylcholine and decrease smooth muscle. And so don't think of opioids as activating the parasympathetic system. Instead, think that they stimulate specific brainstem nuclei, like the Edinger-Westphal nucleus, which causes constriction. It mimics a parasympathetic response. And that's what causes the meiosis, right? The ocular motor, we went over that at Edinger-Westphal. But opioids directly inhibit acetylcholine from the enteric neurons. So it's just about the specific actions that they do in different places. I know that can be confusing, so I wanted to harp on that just for a little bit. All right, moving on to 141. We are indefatigable. Let's go right inside the 4. So we have a 44-year-old man with recurrent lightheadedness, shortness of breath while walking uphill. He's got chest pressure on exertion. Physical exam shows systolic, crescendo, decrescendo murmur heard best at the upper right sternal border, and it's not going to be the right border. Not PAH, that's a loud P2 sound, and not aortic root dissection, that's acute chest pain and diastolic murmur. This is aortic stenosis. Just remember, all physicians take money. Aortic stenosis, the pressure is going to be kind of systole phase when it's squeezing through from the mitral over to the aorta. Okay, in our next question, we have a 30-year-old man sustaining a knife injury to the lateral aspect of his forearm. He notes numbness over that part of his hand, and 2 months later, the sensation returns. Which cell type is responsible for facilitating his nerve regeneration? The Schwann cells. This is textbook peripheral nerve regeneration, because it's on the peripheral sides. So that's pretty simple, right? These oligodendrocytes do not aid in regrowth. They just inhibit regeneration after, and it's CNS, myelin. Astrocytes form glial, and they prevent axon regrowth. Satellite cells involved in muscle repair, not the nerves. And fibroblasts, important for scar formation, but not nerve guidance. So nerve repair, axon regrowth, after nerve injury, peripheral, definitely Schwann cells. They can also help to remove debris, which is nice. All right, moving on to 143. So if you guys remember from the other question about bicarbonates leaving, something has to take its place, and it's probably going to be negatively charged, not positively charged. And so in this question, a researcher generates a mouse strain with red blood cells that lack carbonic anhydrase. The mouse is hemodynamically stable. What is going to be found is going to be increased chloride. So without carbonic anhydrase, you can't convert CO2 to bicarbonate, and that means that there's less of it to export. And so to compensate, you have the chloride that's pushed into the plasma, which then keeps it a little bit more normal. So increased bicarbonate, it would be reduced. Decreased chloride, it needs to compensate, so no. Increased potassium, that'd be bad. And increased CO2 content, it can accumulate briefly, but it's diffused and buffered elsewhere. So normal red blood cells, CO2 enters the red blood cells, converted to hydronium and bicarbonate through carbonic anhydrase. But in carbonic anhydrase deficient red blood cells, less of that is made, and so you have a reverse exchange that causes more chloride. So chloride is key for compensation in that case. All right, next for 144. Here, all I really want to tell you is that there's a Prussian blue stain, and then think of the buzzwords associated with that. And if I also were to tell you bronze diabetes, that should key you into iron overload, hereditary hematochromatosis, cirrhosis, diabetes, skin darkening. Boom, boom, boom. So 60-year-old man, fatigue, arthralgia, darkened skin, transferrin is 84. He's definitely got granules that stain blue, the Prussian blue stain. Iron accumulates, causing hereditary hematochromatosis. It's not eosinophilic globules. That's alpha antitrypsin, would be the eosinophilic globules, would be melanin. All right, next is 145. Researcher isolates novel RNA virus from the patient. It's enveloped and has single-stranded positive sense RNA. Studies show that the viral genome can be translated into protein. What is essential in the replication of this virus? It's direct translation of viral RNA. So this is going to be like a coronavirus. So the genome is immediately translated in the host ribosome into viral proteins. It's got the positive sense already. It doesn't do nuclear transcription, that's DNA viruses like herpes, or reverse transcription, that's HIV, or integration of the host genome, that's a retrovirus stuff, not coronavirus, and formation of DNA intermediates, that again is the DNA viruses. This is RNA coronavirus, and it just skips that step, so it's just translation by the host ribosome. For this question, I want to start with the pathophys. It's beta blockers. And these guys inhibit the beta-1 receptors on the SA node, and that has the result of decreasing CAMP. Decreased CAMP means that the opening of the funny currents will occur when we have the slower phase 4 depolarization, so there's a longer time to threshold. So that phase 4 depolarization takes a longer time, and there's decreased heart rate, and the clinical effect is bradycardia. So you have a prolonged PR interval. So bradycardia via the SA node suppression and the phase 4 slope is the key to the heart rate regulation. In this practice question, we have an 80-year-old man who's got recurrent episodes of lightheadedness. History of atrial fibrillation, started on new antihypertensive. ECG shows regular P waves, narrow QRS, and then 4 days later, his pulse normalizes to 76 with no further symptoms. What explains the bradycardia while on the medication? So he's on a beta blocker, propranolol, that inhibits beta-adrenergic stimulation, lowers CAMP, answer is decreased slope of the phase 4. So looking at this, our beta blocker decreases the calcium that enters in phase 4, decreases conduction velocity, decreases firing, decreases heart rate. So here's the phase 4, slowing things down. Here's the pacemaker action potential. There's threshold, phase 4, phase 0, and 3. 4 is the funny currents. 0 is the L-type calcium channels, and then 3 is the voltage-gated potassium. Funny, calcium, potassium. Here's the Purkinje fiber, potassium efflux. Sodium influx, calcium, repolarization. 403. 403. This is the SA node, by the way. 403, 403. And that's the calcium there, and then it's the sodium here. So it's that slow entry. Now, it's not the sodium channels, because the fast sodium channels are in myocytes, not the SA node cells. And the calcium influx, phase 0, that affects the conduction speed of the SA-AV nodes, not the heart rate per se. And the plateau phase is more relevant for ventricular myocytes, not pacemaker cells. We're talking about pacemakers here. And potassium efflux that affects repolarization, not the rate of spontaneous depolarization, which we're talking about. And so the heartbeat is driven by a slow trickle of sodium and potassium ions that's called the funny current. And beta blockers, like propranolol, hit the brakes on that current. And the way that they do that is they block the beta-1 receptors in your heart's pacemaker cells. That lowers the CAMP and slows the diastolic depolarization or phase 4. And as you saw, 403, 403, right? That means the SA node takes a lot longer to fire, and that means it's a slower heart rate. So in a patient with propranolol, it'll slow that phase a little bit too much sometimes, and it causes bradycardia and fainting. So is the decreased phase of 4 in the pacemaker that causes all of this stuff. The beta blockers, the decreased CAMP, the funny current. That's what's going on. We got to the bottom of it. Now, I'm going to rephrase this question. I'm going to ask, what are antimuscarinics like oxybutynin used for? What are they first-line therapy for? And that's just as good of a question as this one, which is 64-year-old woman, comes to the clinic, frequent urgent episodes of leakage when she hears running water. What explains her symptoms? She's got destrucer overactivity. That's what's going on. She has urgency and leakage in response to auditory or anticipatory cues without physical strain. It's urge incontinence, and that's the uninhibited detrusor muscle. So first line is going to be bladder training and antimuscarinic agents. Stop all that contracting, right? External sphincter, that would be continuous leakage. Urethral hypermobility, stress incontinence. That's with increased pressure, like sneezing, coughing stuff. Bladder outlet, obstruction, that's overflow incontinence. Impaired renal concentrating ability, polyuria, not urgency. So the way to really dumb down urge incontinence is that the bladder muscle called the detrusor freaks out and it squeezes too soon even when the bladder isn't full. And why does this happen? The detrusor muscle is supposed to be chill, right? In urge incontinence, it spazzes out. It's a false alarm. And what triggers it is the sound of water. It's not the coughing and the pressure stuff. So it's stress incontinence would be, the sneezing, the pressure, all that stuff is stress incontinence. And so the key is it's not about your sphincter or too much urine. It's about your bladder muscle contracts when it shouldn't be contracting. That's called detrusor overactivity. And then you have to think about what would fix that. Well, oxybutynin, that calms the bladder by blocking the parasympathetic signals, because the parasympathetic, that's what's causing that contraction. And so wouldn't it make sense to block something like antimuscarinic to block the parasympathetics? And that's exactly what oxybutynin does. So this is urge incontinence. Hopefully that makes sense. All right, now in our next question, which is 147, we have a 30-year-old man who is undergoing a urodynamic study as part of a research experiment. During this sympathetic stimulation, his prostate gland contracts, leading to emission. Neurotransmitter is responsible for mediating that contraction. Remember, point and shoot. There's the parasympathetic for pointing, and then the S for shooting. This is the shooting process, so it's the sympathetic. Because it's the sympathetic nor the symp, it's going to be E, norepinephrine. Sympathetic, boom, done. Acetylcholine is used in postganglionic sympathetic nerves to sweat glands and by parasympathetic neurons, not the prostate. Epinephrine, secreted by adrenal medulla in the blood. Glutamate, CNS excitatory. And dopamine, brain and kidney. So most sympathetic nerves, they're just the fight or flight thing, right? They use norepinephrine for that. But there are two big exceptions. One is the sweat glands. That's the neurotransmitter, right? The sweat glands, acetylcholine, not norepinephrine in the sweat glands. The receptor is muscarinic. In fact, it's an M3. That's the exception. Onto the postganglionic sympathetic nerves. And these post guys, usually they're just going to release norepinephrine. And that's usually the case. But the adrenal gland and the sweat glands, those guys are still like sympathetic stuff, but they're innervated by acetylcholine. So to say this even more simply, we're talking about the sympathetic nerves and when they don't use norepinephrine. So usually, like most of the time, you get the brain, the spinal cord, the sympathetic nerve sends the signal. So just to keep this super, super simple, preganglionic neurons from the spinal cord release acetylcholine. They release that onto a ganglion where the next neuron lives. And then postganglionic neurons from the ganglion release norepinephrine. And then they go to the target tissues like the prostate, the heart, the blood vessels. So it goes spinal cord, ACH, to the ganglion, and then norepinephrine to the target. So a good example of this is the preganglionic neuron uses acetylcholine, and then the postganglionic uses norepinephrine on the alpha-1 receptors of the prostate. That causes smooth muscle contraction, leads to emission during ejaculation. So it's a sympathetic response there. Norepinephrine is used on the postganglionic sympathetic nerves. However, on the sweat glands, it's a little bit different. You just use acetylcholine all the way. In the adrenal medulla, you use acetylcholine as well. And also the parasympathetic uses acetylcholine, like the salivary glands and stuff. So just knowing those two exceptions is the most important part. All right, moving on to 149. If they give you a graph that kind of looks like this, then you have something like over here that's like way high, then that is going to be the mode. Like if this is the frequency, this is the mode, and that mode is pretty high, so the mode is going to be the most high. And then they could ask you about like the median and the mean. And what you have to know for the median is you cross out things until you get skewed, and it should be skewed a little bit to the right here. And so the median would be somewhere around here. But if there were like tons of them, tons of low values as well, then the mean would be even lower, even though the median is high and the mode is super high. So just knowing the difference between those is super important, but they're really easy. So I'm not going to labor on that point. Instead, I'll just go to the last question. All right, for question 150, what we're going to do is this last question. In the experiment, tumor cells are injected in genetically identical mice. One line has normal MHC class 1, the other has no MHC class 1. What's responsible for controlling the MHC1 deficiencies? It is going to be natural killers. Their job is to identify those who don't have the MHC1 stuff and kill them, right? So the natural killers recognize the sites that lack them and kill them with perforin or granzyme. So that's the answer. Boom. All I'm going to draw on this one is natural killer cells love none. They love it when you don't got nothing. But if you got the MHC, you're okay. And so if it's MHC negative, then you're going to die. In a very meaningful way, you will die. All right, folks. And that is all there is to it. Holy cow. I just wanted to thank you guys for watching this. Hopefully you like this green screen setup. If not, let me know. I'll just throw the green screen down. Look at that. I still got the same setup behind. You just can't even see it. But thank you guys for watching. Please be sure to like, comment, and subscribe. All in all, I've taken, I think, over 100 hours making these videos. I just really want to make them high quality and good for you guys. So let me know what I can do. Hopefully we can eventually get to 500 subscribers. That would be a dream come true. And let me know how I can improve. And with that one, we'll see you guys in the next video. Take care. Bye.